If you look at this case, what is the patient's complaint and what is my goal? The patient's complaint was, I'm not able to keep this area clean. And my goal in treating this area could be for sure not to obtain complete root coverage, because complete root coverage in this RT2, 3 chiro class, it's impossible because I have the exposure of the interproximal cementonomal junction. I have the lack of interproximal soft tissue. So achieving 100% complete root coverage is not possible. So here I wanted to address the patient's request, and I wanted to improve the quality of the soft tissues below this gingival recession. In this case, my goal is to improve the quality of these tissues to make it easier for the patient to maintain oral hygiene and to increase the depth of the vestibule. So the free gingival graft is the ideal technique. But remember, you don't have to place the free gingival graft at the level of the cementoenamel junction, because if you place the free gingival graft at a level that is impossible to cover from a biological point of view, you know that this portion of the graft will shrink completely. We want to improve the quality of the soft tissues without trying to completely cover the gingival recession. So, if you look at the surgical video, you'll see that after the anesthesia, there's a complete lack of vestibular depth. When the vestibule is filled with the anesthetic liquid, you can see that when I pull the lip, the muscles of the lip are inserted perpendicularly right at the level of the gingival margin, which means that the vestibular depth in this area was 0. Now, I have to create my recipient bed by making this trapezoidal flap design with two 3mm horizontal incisions, one measured to the mesial of this central incisor and one to the distal of this central incisor, and two vertical incisions that are almost parallel, and the interradicular incision made between the two central incisors creates this trapezoidal papilla. Thickness elevation of the surgical papilla. We only perform a split flap elevation, keeping the blade parallel to the bone to create this periosteal area that will provide vascular supply to the free gingival graft. So, my blade is parallel to the bone. It's in contact with the bone, separating the alveolar mucosa and the muscles from the bone. I feel relaxed. If there's a perforation, who cares? I'm going to cut away the flap anyway, since I only need to prepare a recipient bed. So, I can feel very relaxed during this flap elevation as long as I keep the blade parallel to the bone. I remove this muscle insertion because, as I mentioned before, I don't want anything between the periosteum and the flap, since these tissues could destabilize the early vascular anastomosis. So, I really need to ensure as tight an adaptation as possible between the inner part of the graft, the periosteum, and the recipient bed. Now I can trim away my flap. And you can see the recipient bed is now ready. It's a very simple and easy technique, as you can see. I'm only going to instrument the root on the portion that will be covered with the free gingival graft. The most coronal portion of the root, this part here, which will not be covered, should not be planed, because otherwise the patient will definitely experience dentin hypersensitivity. And since I don't intend to try to cover it, there's absolutely no point in performing root planing on that area. Then we apply ADTA gel. Now we have to measure, you see, the apicocoronal dimension of the free gingival graft that we need to harvest from the palate. And you can see that this is the level of coverage. So, going back to the apicocoronal dimension of the free gingival graft, since this is the coronal position of our free gingival graft, because, as we discussed earlier, we don't want to completely cover this recession, since it's not possible to achieve full coverage. So this is the position of the graft. So from this level, we need to go 3 millimeters apical to the buccal bone. So in this case, it will be a 7 millimeter. Measured distally, it should have the same dimension as the connective tissue graft, meaning the distance between the two vertical releasing incisions. In that case, it was probably, I don't know, 10 or I didn't see the probe measuring this distal dimension, but it was probably around 12 or 13 millimeters and a 7 millimeter height for the free gingival graft. And as you can see, only at the end, when the graft is completely lifted, do we make the final apical incision that connects the two vertical incisions at the apical portion to detach the free gingival graft from the palate. On the inner side of the free gingival graft, I remove the fatty tissue because, once again, I want to have dense collagen tissue on the inside, which is stable. As I mentioned before, the only real risk in this procedure, the risk of failure, is if we can't provide enough blood supply to the free gingival graft, and it ends up becoming necrotic. The only two possible mistakes are that I might not secure it properly and the suture could come loose, which would obviously mean losing the graft, or that I can't achieve a tight and stable adaptation between the inner side of the graft and the periosteum. So, in this case, improper stabilization of the free gingival graft increases the risk of necrosis. So, I remove all the tissue that isn't stable, the movable, fatty tissue, in order to have the best possible tissue to place over the periosteum. Now, the free gingival graft is ready, with connective tissue on the inner side and epithelium on the outer side. I place the graft exactly at this level. This is the level where we can predictably achieve coverage. We are not going to achieve coverage on this part of the root, so we begin to position the graft, anchoring it to the buccal side of the anatomical papillae that have not been deepithelialized. I tie my knot as usual on the graft side, because the rule when tying a knot is always to secure it on the part that needs to be stabilized. The needle exits on the stable buccal side of the anatomical papilla, and I tie the knot over the free gingival graft on the mesial side, the distal side, and then in the interradicular area. In the interdental area, it's done the same way, using 6 to 0 PGA suture material. Now, the free gingival graft is stabilized at the coronal aspect. Now, I need to secure the apical angle, and this is done with this horizontal external mattress suture. By piercing the graft, the needle exits through the adjacent tissues, and then, from the outside, it comes back, anchoring the periosteum on the way back. However, on this side, it does not pierce the graft from the outside to the inside, because with this type of external horizontal mattress suture, when I tie my knot, I firmly secure the angle above the periosteum and pull it toward the outside, since the periosteum has been anchored externally. So this mattress suture firmly adapts the angle of the graft to the periosteum, stretching it laterally. The same thing is done on the other side. The needle goes through the graft and external tissues, then comes back from the external tissues, anchoring the periosteum on the way back to achieve this stretching of the graft, without piercing the graft again on the return. So now the graft is adapted and secured all around, so there's no way for the graft to move. But I need to improve the stability of the blood clot in the central portion because here, if I try to touch this area of the graft with a probe, you can see that it's movable. And if it's movable, it means that you can have excessive blood clot formation that, during the immediate postoperative phase, can become destabilized, which would destabilize the early anastomosis. So I need to anchor the periosteum apical to the graft, suspend the suture around the tooth in order to create this suspended suture that tightly compresses the graft above the periosteum and the central portion. I don't like to cross this suture. I prefer to keep it parallel so that there isn't a crossing area that creates compression in just one spot, because that could cause some vascular trauma in the area of compression. So I prefer to keep the two sutures parallel, but that's just a detail. You can see a horizontal perforation with a needle in the periosteum apical to the free gingival graft. Then I go around without crossing the suture and I close the notch. And you can see that these two parallel sutures are compressing the graft in the middle to reduce the mobility of the central part of the graft in order to provide the best possible vascular support between the inner side of the graft and the periosteum. And this is the healing process. Does it look good from an aesthetic point of view? Again, no. It's very easy to spot this scar area because the healing of the free gingival graft is like a keloid. But the patient is very happy because now, with this band of keratinized tissue, they're able to clean this area very well and maintain excellent plaque control. So now, I don't have any risk of developing a buccal probing pocket depth. The vestibule depth has increased significantly, and the root has been covered as much as was biologically possible. So the result is satisfactory from both the patient's and the professional's perspective. You can see the increase in vestibule depth, which is clearly visible thanks to the graft that maintains and creates this verticality. And here is the patient comparison between the baseline and the final result. So it's an easy, predictable technique that can give us a lot of satisfaction.